Welcome, everybody, to another fantastic FDN Lab and Learn with Reed Davis. That's me, and of course, our science officer, Dr. Aron Gonshor, who's going to go over another lab that we use. It's a very popular lab, menstrual cycle mapping. And we're going to jump right into it. You'll learn when you should use the menstrual cycle mapping, the importance of it, how to enhance that information with the other data you might collect from your client or patient. And also we'll be going over the individual lab markers, very, very important. And with that, I'm just going to turn it right over to Dr. Gonshor.
Well, thank you very much, Reed, and hello to everyone. We're continuing with our series, and as we've done on previous sessions, we're actually going to be doing a a case report, and I'm just letting you know that this is the case study that we're going to sort of discuss later on, and it's going to be on one of the issues that can occur with women who are having problems with their menstrual cycle. It's called a luteal phase shift or deficiency. So I'm just letting you know that we are going to be discussing this particular case report. We're going to go over it in just a few minutes. And so let's see, how do we get this? There we go. So we're going to discuss menstrual cycle mapping, and it is a very important test, and especially for those practitioners who are dealing with women who are having menstrual cycle issues, would like to know why they're having problems with infertility, etc. And we're going to go through that in detail. So as an overview, let's just remember, we're doing a quick tour of this from 30,000 feet up. We do have lectures where we go into great detail about cycle maps and etc., but not today. Today, we're just going to give you a quick tour. So just to remember, a menstrual cycle has evolved to follow the lunar cycle, which is around 28 to 30 days. And even though it may vary from month to month, different women, but in general, people will say, yes, I have a 28-day cycle. And that's what you would normally expect. And what you need for a normal menstrual cycle, even though we sort of say, oh, yeah, there's no problem, I have a normal cycle. For that to happen, you really do need to have everything lining up properly. And that means that you need an intact hypothalamic pituitary ovarian axis. We'll go over that. You need to have follicles. Those are the areas that are going to create eggs in the ovaries that are actually responsive, that they're working properly. And on top of that, you have to have a functioning uterus that's going to accept the egg, etc. So all of that needs to happen. And when we do go into great detail on some other lectures, we actually discuss the 4 phases of a cycle: the follicular phase, the ovulation, the egg actually leaving the ovaries and coming into the uterus, the luteal phase, the buildup of that uterine wall in order to accept the egg and get it ready, and of course, menstruation, if and when it does happen on a regular basis. So we're not going to discuss that in detail, but that's what you need to really know. So a menstrual cycle map. When should it be considered? When should this test be done? Well, it's ideal for cycling women who really are interested in knowing what's their hormonal level during a whole cycle, not just a pinpoint in time on one day, what's going on throughout the cycle. And you need to know that when you're trying to deal with the issue of infertility, because they come to you and they say, I am not able to conceive. Why is there an infertility issue? And part of it may be because of a cycling imbalance. And that's getting to know, in that case, the root of these various difficult menstrual symptoms, which I'll discuss in a few minutes: premenstrual syndrome, premenstrual dysphoric disorder, migraine headaches, you name it, a whole number of issues. It's also ideal for women who are entering perimenopause. Now, that's a phase that comes prior to a woman's final menstrual cycle. And it happens gradually for most women as they get into their mid or late 40s, some a little bit later. It can last about 5 to 7 years. And during that time, it's characterized by declining fertility for a number of issues and fluctuating hormone levels. So, women in this situation are going to want to know what is going on with their cycle, which may be not only giving them a problem with conceiving, and most aren't conceiving at that point, but they're having a lot of symptoms and they want to understand why. So, to give you a very quick idea, this is a very busy slide with all kinds of things, but here is a 28-day cycle, the classic 28-day cycle that we normally deal with. And the first hormone that is going to be of importance is produced by the pituitary, and it's called the follicle stimulating hormone. And that's the hormone that causes the egg to begin to mature in the follicle. It's still in the ovary, but the body is saying, start maturing because you're going to be leaving the ovary to go into the uterus. And when you stimulate the ovaries, you're stimulating them to produce estrogen. And the estrogen, as soon as it starts being produced, is going to inhibit this FSH, this follicle stimulating hormone. Says, thank you very much. You've got me to start going. I don't need you anymore. It's also going to make sure that progesterone is kept low at this point. Well, there's the estrogen, in this case, estradiol, the most important one. And it starts to cause the uterus to begin to build up a wall and a lining that is going to accept the egg. It says, okay, I know an egg is coming. I want to get the uterus ready. That's what the estrogen does in this follicular phase. That's the phase before ovulation. And then at some point just before ovulation, you have what's called a luteinizing hormone. And it is stimulated by estradiol. And what it does is it says to estradiol, thank you very much. You've done your job. I don't need you anymore. And I am getting ready to get the ovulation going. Then, of course, you've got progesterone, which after ovulation, it is the hormone which makes sure that that uterine lining is maintained for the egg. It inhibits the release of other eggs. It says one egg is enough. Thank you very much. And we're ready to go. And it is going to be there as the key hormone if, in fact, a pregnancy occurs. In other words, if that egg is going to then come together with the sperm and you are going to start getting an embryo to form. So that's just a quick look. And so here is a typical look at the first page of a normal menstrual cycle report. The page is actually much longer, but what it does give you are two large schematics. And it's showing you where estradiol is throughout the cycle and where progesterone is throughout the cycle. It also gives you the actual numbers within the 9 days that we test. So during the cycle, with this particular test, we will be testing during 9 critical days of a cycle. And in each one of those 9 days, we are going to look at where estradiol is and where progesterone is. And that's the way you can create a curve to know exactly what's going on. So in this case, if someone has a normal cycle, you would expect the peak of estradiol to be just before ovulation, which normally will come at around the 14th day of a typical 28-day cycle. And of course, as we move along, you are going to see the peak of progesterone coming about a week, about 5 to 7 days after ovulation. And of course, we also give the reference ranges, which those of you at FDN know very well, because that's what we will see when we do a typical salivary hormone test, a stress test that we do, stress and hormone profile. So I'm going to spend the next few minutes, again, just very quickly going over cycle abnormalities, some of the things which can cause problems and will have an individual coming to your office to say, I have a problem, can you help me with it? And some related dysfunctions, which I'm going to make mention of. So let's just look very quickly at some of the classic abnormalities which will cause problems for the menstrual cycle. And we're going to look at 5 main things, beginning with irregular cycles. This is by far the particular abnormality which will be coming together when a person comes to your office. So irregular menstrual cycles. Cycles are too long, they're too short, which of course creates a question for many people. When is it best to test? Well, one of the ways of knowing when it's best to test for whatever it is to know what's going on during that entire cycle. And a regularly long menstrual cycle, we define as anywhere greater than 32 to 34 days. After 35 days, it is an absolutely long cycle. And in these situations, both the estrogen, in this case estradiol, and progesterone, they are peaking within normal ranges. The height is pretty good, but it's coming at the wrong time. And here, for example, estradiol is way, way late. It's peaking about 10 days late. And the progesterone is not peaking where it should around the 20th day of a normal 28-day cycle. It's peaking 4 days after that. And that's critical because when they are not peaking at the right time, the egg is not getting the right type of information. The uterus is not organizing itself in the right time, and you end up with infertility. And the most common cause of that is what's known as PCOS. It's a polycystic ovary syndrome. We're not going to go into it in detail, merely to say that to have PCOS, you need to have at least 2 of these following 3 things. You need to have either irregular or absent cycles, an increase in androgen levels, that means male hormone levels, and the ovaries need to be polycystic. And we're going to go over that in just a few minutes. And there are a whole slew of other things that can cause long menstrual cycles, including, and I do want to mention medications, which can cause that, and thyroid conditions and obesity. Many women who are obese are running into similar problems of long menstrual cycles. You can have an irregularly short menstrual cycle. It can be very short, that's less than 20 days. It can be what's called short, that's 21 to 24 days. Remember, that's less than 28. And it can be a medium short, between 25 and 28 days. It's just approximating the normal cycle time, but not quite there. So again, what are you looking at? Short. Here you see this person is peaking before what you would expect in a normal cycle. Same with progesterone. And so the sudden cycle shortening to less than 24 days can be to, again, a whole number of issues. What is most important? Stress, and people who have extreme weight loss or gain. Those are 2 of the most important things that will cause short menstrual cycles. And as you can see, there are a whole number of other things that can cause it. Here is the second group of abnormalities, and it's the one that is going to be talked about in our case report at the end of our discussion today. And that is a luteal phase shifting or deficiency. Remember, the luteal phase is the second or last part of the menstrual cycle, and it is one of the most common causes of infertility. And what's happening is the ovaries are failing to release sufficient progesterone, which the ovaries normally do. And so the uterus lining isn't responding properly to progesterone. And you can get lower peaks of all of the hormones. So the usual peak level of the luteal phase is going to be, that progesterone peak is going to be much lower than you would normally expect. So you define a luteal phase when the luteal phase, which normally would be about 14 days, when it's less than 11 days, you're saying, whoop, there is a deficiency or it's shifting, something is going on. And so we're going to look at some of the reasons that you would have that. Endometriosis is one of them, and that is a very difficult issue for women who has it. The lining, which is similar to the uterus, actually grows outside the uterus, and that causes extreme pain. And so in these cases, you need to know, why is that happening? I mentioned excessive exercise before for some of the irregular cycles, the same for luteal phase. PCOS is one of them. And then again, obesity, some thyroid disorders, and stress can really cause these issues. And what will it show up as? Well, remember, what we're looking at is that ovulation, which is normally on the 14th day, is now being delayed. It can be on the 18th day. It can even be further than that. So it gets delayed in many cases because the estrogen level during the follicular phase is lower than it should be. Or the luteinizing hormone, which is supposed to get ovulation happening, too low, it's just not there. And so that means that ovulation gets delayed and in some cases doesn't even happen. The luteal phase, now that ovulation is coming later than it should in the cycle, the luteal phase may end up being shorter than normal simply because that ovulation is later. So here you see a shorter period than you would have had with a normal cycle. And this luteal phase can do something else. The, the surge of progesterone can come later in the luteal phase than it should. And while it's doing that, it's also less intense. The peak is less than it would be. So this person can have a whole number of possibilities of causing a problem. Here is the third thing, and that's anovulation. Anovulation means no ovulation. There's no egg that's released, doesn't ovulate. The ovum doesn't go out into the uterus. And it can be caused by an imbalance of a whole number of hormones, sometimes only one or many, especially those that are involved in ovulation. And so here is where you get into this issue of what controls the ovaries. Well, here's the hypothalamus that we mentioned before. There is a particular hormone called the gonadotropin releasing hormone. That is the hormone that tells the pituitary what to do. So it can be operating in a abnormal fashion. The pituitary itself, even forgetting about the hypothalamus, it may have a problem with the two hormones that it controls. And we mentioned them earlier, the follicle stimulating hormone and the luteinizing hormone. Both of those can be imbalanced. And you can end up with very high androgen levels, testosterone, prolactin, and that can throw everything out of whack. And what else can? Well, the thyroid. And if the thyroid is imbalanced, that'll cause major issues. So remember, you always need to test for thyroid function to make sure that that is operating well. And the complications of anovulation, of no ovulation, is, well, infertility, because there's no ovum. The egg doesn't come out. Amenorrhea, there's the absence of a regular menstrual period, and various kinds of hormonal imbalances, which can cause any number of ovulating problems, as well as other symptoms. So women who are gaining weight, hair loss, acne, that should give you a clue that there is an issue. And here it's pretty straightforward. There's no ovulation in this particular scenario. So what do you see? There is no estrogen rise, neither in the follicular phase or what happens with estrogen. It'll have a secondary bump normally in the luteal phase. It doesn't have any of that. Neither do you see it with progesterone. So it looks like a flat line. So when you see that, that's pretty clear. That has to be dealt with and to find out why it's happening. The next group, and again, we're doing this pretty quickly, is amenorrhea. Amenorrhea is an absence of menstruation. during a woman's reproductive years. And there are two types. There's primary and secondary. The primary is for a young woman that has no history of menstruation past the age of 15 or 3 years after thelarchy, that is the beginning of breast development and so on, which normally would mean that you start to have normal menstrual cycles. If it doesn't happen, that's primary amenorrhea. And you can have secondary amenorrhea, and that's the absence of any kind of menstrual cycle for over 3 months in women who have previously had regular menstrual cycles, or greater than 6 months in any woman with at least one previous spontaneous menstruation. In other words, they had at least one menstrual cycle and then it stops. Why? So that's something to remember. I'm not going to go through all the reasons for amenorrhea. I do just want to mention the fifth, the last one we're going to discuss, and that is hysterectomy. And there are women who have hysterectomies, either partial or radical. And many of you know about this or have had it. A partial is called a supracervical hysterectomy, and that's a surgical procedure where you remove only the uterus. So you leave the cervix, everything else, the ovaries, everything else is held in place. So there are cycling hormones, but there's no menses. And you can have a radical hysterectomy, which is the removal of the uterus, the cervix, the upper part of the vagina, etc. And that is normally due to cancers of the cervix or the ovaries, etc. So hysterectomy will cause a problem. I am not going to go into this in great detail, except to just let you know that there are normally about 5 related dysfunctions which you need to keep in mind when you're doing this. One is just menstrual migraines, and it's caused by hormonal fluctuations, especially very precipitous, very dramatic drops in estrogen and progesterone levels. And that can cause very severe migraine headaches. And I think that that needs to be kept in mind for many women who do come in with that as a major symptom. The other symptom that you will hear many women come in with is premenstrual syndrome, physical and behavioral symptoms that some women experience, unfortunately, every month, normally after they ovulate and before they start menstruating. So that would be in the luteal phase. They're going to tell you that they have a whole series of problems, symptoms that are going to occur for a number of days, and then it's going to get better at the end of that. So what are some of these that you see? And I found this diagram which tells you some of the physical and psychological signs and symptoms. And what do you get? Mood swings, very low mood, increased anxiety, easy crying. And these are people who normally have not had that. And suddenly this begins to happen. They have the headaches, the fatigue, poor sleep, etc. Remember, I mentioned acne and oily skin earlier. You're going to see that. Their breasts will quite often get very tender and swollen. They're getting menstrual cramps, etc. And of course, constipation and diarrhea. When you start to see this constellation of symptoms, you need to think of premenstrual syndrome. I am not going to go into premenstrual dysphoric disorder, only to say that in about 10% of women, this is like a premenstrual syndrome that is much more severe. The etiology is unknown. We don't know why it happens, but you do get that. Remember, I mentioned earlier the polycystic ovary syndrome. And just to remind you, many women have that, especially those who are obese. And the signs: high androgen levels, irregular or complete absence of menstrual cycles. And when they're checked, they're found to have polycystic ovaries. And I just showed this, that you actually have ovaries with a whole number of cystic areas within the ovaries. That is not normal. So you have to keep that in mind. So let's look at our case study. The case study here, and read, I hope that you're listening here because we're going to discuss this case study.
Of course.
Okay. So in this case study, which, and I'm letting you know beforehand what it is, so it's a little unfair. I'm not asking you to figure it out, but this would be the type of thing that might happen. The patient is 32 years old and has been trying unsuccessfully to conceive. So it presents at a fertility clinic, and the history is, well, two early pregnancy losses, miscarriages. One was at 6 weeks of gestation, the second one is at 8 weeks. And the history is that this particular woman, who's quite young, has regular menstrual cycles. She has no known underlying medical conditions, but she's under chronic stress due to various familial issues. She's undergoing evaluation for thyroid dysfunction. And she's been told that the infertility is potentially due to inadequate progesterone production or some kind of endometrial receptivity. In other words, that the luteal phase may not be normal, and that the luteum, that lining that is being created to accept the egg and then allow for fertilization, may not be functioning properly. So what would normally be done is, if the clinician orders a test, and by the way, it's a fluids IQ test. I haven't told you, but our our lab is fluids IQ. I don't mention it normally, but here it is. And this is the test that we would offer. And this would be the first page. And the first page would tell you all about the patient. And then you would see the menstrual cycle. And as I showed you earlier, at the beginning, it'll tell you what were the levels of estradiol and progesterone on the 9 days that saliva was taken. This is a salivary test. And we ask the individual to drool into little tubes. There's an instruction manual for 9 of the days of the cycle. And these red dots connected by these lines are the actual numbers that you see here above, both for estradiol and for progesterone. And this is the form that comes in the kit that says to the person doing the test, do your first saliva tube on day 7, do your second saliva tube on day 10, etc., etc. And that's the way in which you would do the test. And so what do we see in this particular case? I showed it earlier, but let's take a look at this. So what do we see here? Well, we're finding that this particular individual has had delayed ovulation. The ovulation has shifted. It's gone from the normal 14-day to 18-day. That's a 2-day shift. That's pretty long, and it can be even longer, by the way. And not only is there a shift, but in this case, there's also a deficiency. In other words, the level of estradiol, and we'll discuss progesterone in a minute, not only is there a shift in ovulation, but the estradiol, which would normally be one of the things leading to ovulation, it is a little bit lower than it should be. So it's not giving as strong a signal to get the ovulation happening at the right time. Well, what about progesterone? Well, remember again, here is that shifted ovulation. The progesterone is coming earlier than it should in this new time when things ovulated. And look how much deficient it is. So the progesterone, which is supposed to prepare the bed, it's supposed to prepare the luteal area for the egg, is not giving enough of a signal. And therefore, the egg, when it finally reaches the bed, sees that the bed is not ready. And it can be even worse. Not only can it be deficient, but that peak is happening even later than it should. So this person now has not only a late ovulation, but the bed is not being prepared properly at all. And the egg said, I've had it. I cannot do what I need to do. And that person is going to have a problem. And so That, folks, is a very quick walk through the menstrual cycle map. And as I said, we have a long lecture in which we actually describe what is a luteal phase, what is a follicular phase, and we take you through what those areas of a woman's anatomy are that allow for that to happen. But we're not doing that today.
Well, that was an amazing overview, Dr. Gonshor. I really appreciate it. I think back to the days in the office when I ran a lot of these because it was more readily available. I'm really glad that Fluids IQ has brought this test back to the forefront because people out there, they're running a lot of saliva tests. They know they have a client who's under stress, kind of the prerequisite to be visiting an FDN practitioner. And they're also having the long cycles. They're having the short cycles, the infertility and ovulation. They're not even ovulating, like you said. The amenorrhea, they've got heavy bleeding sometimes, other hormone imbalances. Obviously, we see a lot of PMS and even PCOS and these kind of. So we know we have a person who's got more complex hormone issues or problems than what you can get from the single day. And we often are telling our clients, like we want you to test kind of in the middle there where you might catch something being high or low. But why guess when you can run a better test? Just run the whole cycle and you'll see the problems, whether it's late ovulation or no ovulation, or you're just not getting enough progesterone to build up that luteum as you described so perfectly. So I thought it was a great overview. And I really think this test should become the forefront of working with women who have all those hormone issues that we talked about, whether it's long or short or infertility, the anovulation, dysmenorrhea of any kind, PCOS, and these kind of things. So we're getting the clients who need to run this test. And so thank you for bringing this out.
I wanted to tell you, and it's one of the things we're going to discuss. I want to thank you, first of all, for suggesting that we offer the test because we were going to do it many years ago. We didn't. And I have to say, and I'm saying to everyone listening, I think it was you, Reed, who said, this test, and you said it just earlier, in my practice, so many times, I needed that test. And it's so true. And I'm going to give you an example. And we're not going to discuss today the difference between 24-hour urine or if you're doing the Dutch test, whatever it is. Remember what that is. You are looking at a whole list of all kinds of primary hormones, metabolic pathways, etc. Wonderful, wonderful. But there's one problem. The problem is, as you said, it's being done in one moment in time. So you've got all this wonderful information and you're looking at it and you're saying, whoa, wait a minute. But this hasn't answered my question. And the reason it hasn't answered it is because you didn't look at this throughout the month. So you need to sometimes add this test to whichever way you're going to do a total urine analysis, whichever one you're going to choose, and add the menstrual cycle. So now you get the full picture. Now you understand what may be going on. And you can say, Mrs. X or Y, this is why we're having this problem. And together with this whole list of 25, 30 metabolic pathways and so on, now we're getting a measure, a real measure, and it's giving us the true pathway of how to get you better. And so I really think
Yeah.
this is an extremely important test.
You know what I think is so wonderful about this test is it explains exactly why someone's feeling as lousy as they feel and having all the symptoms that they're having because they're actually mapping out their menstrual cycle. Remember, the lunar cycle is so critical. Just like we have our daily circadian rhythm, which we look at, we have the monthly rhythm and other rhythms and things. And so when you look at the whole thing, it makes a lot of sense. Here, Mrs. Smith, this is why you feel so lousy on day 14 or day 20, whatever it is. They've got the PMS thing going on. If they got no ovulation, they can't get pregnant. Oh, so I love when test results explain why a person's presenting the way they are. It's why we test, and this is just a wonderful, wonderful tool to add to our all of the wonderful things we can do for people. Because it does help you explain, how do you fix this? Well, you can just see the effects of stress upon the HPO axis that you described. The hypothalamus, it's hypothalamic, it's pituitary. It's not just the ovaries. And there may be nothing wrong with your ovaries. It's just the signaling
There you
from
go.
epigenetics, which is the root of our remedies anyway, is to get people back to normal life, normal cycling, and through natural lifestyle based medicine, if you will.
I would say to you that I'm a little embarrassed that we had not, as a lab, offered it when we were originally going to do it many years ago, because this is such a window that opens up to really seeing what's going on that you almost say to yourself after you get used to using it, what was I thinking beforehand? With so many women coming in, as you said, with all of these symptoms, and spare me someone who says, "Well, I think I know what it is." No, 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 no. Let's not go there. Let's not go
Yeah,
there. No, you don't. You've got to actually see it. And if it does say, exactly what you thought is what's going on, thank you. Okay, that's fine. But what if it doesn't? What if it doesn't? So I think at the end of the day, that is important. One of the things that people have asked us, well, why don't you offer the luteinizing hormone and the
sure,
stimulating hormone, etc.? And the answer to that is, you know what? We could offer about 10 other hormones.
sure.
If you want to go down that path and you want to spend a few $1,000s, sure, I'll open up the machines and I'll order a whole number of them. But come on, guys. The thing is, you don't really need them. You're going to see what's going on. At that point, if you want to get into the weeds and importantly want to really look at some of those things, sure, there are other tests, always. But in the beginning, you want this overall landscape look. You want to just get an idea of the environment. And that, in a vast percentage of cases, will tell you what's going on. And I just wanted to also add, Reed, as you said, for most people who are clinicians in this area, the healthcare professionals, anybody who's listening to this should be shaking their head and saying, yep, I see women coming in with this every day. And if I do, if I don't, and I keep shaking my head right now,
Mhm.
not doing that, then I'm either not in practice or I have to ask myself, who am I really seeing? Women have this problem all over the place, and it can truly be helpful.
Yeah, well, again, if I played any part in Fluids IQ bringing this test back out from out of the shadows, I'm pleased about that. And I have to say, I spent all those years in the clinic, but I also spent a lot of years as a clinical advisor for a laboratory, just part-time while I was building FDN and doing all these wonderful things. But and I would have clinicians on the phone going over test results, and all they had run was one or two little labs. They just didn't have enough data to really resolve the person. And I would recommend this test. We had an 11-day, we had a 17-day. There was different ways of skinning this cat, but the next time I'd get on the phone with it, it would just completely help resolve the person's problem. Oh, now we see where all of these problems are coming from. Tests don't guess, and the test should explain exactly why person's having the problems they're having, and then the natural remedies would flow from that. They flow from knowing what's really wrong, and FDN is entirely built upon your epigenetic program, your diet, your rest, your exercise, your stress reduction, your supplementation, that should flow naturally from having the data and connecting all these dots. It's no, matter of fact, it's neat to see the dots connected right there in front of you, the estrogen and progesterone. And I'm glad you mentioned that you don't have to do a lot deeper than that unless you got a really severe case or something, the luteinizing hormone and the other things. you can always run the SHP as well as um, and I would do both. So I think for FDNs listening to this, once you run one or two of these, you won't go back. You'll be doing it with almost every client because you'll be getting a better result. You'll have a better understanding. And when you have a better understanding, your client gets it. They will be thankful that you actually, well, I can't, they say to us all the time, I can't believe you figured it out. And they've just been chasing symptoms up until then.
No, you're absolutely right. And by the way, you did mention there were the 11 and the 17-day and so on. Theoretically, you want to really do a saliva test every day. Of course, you're going to see the entire cycle and you're going to spend a few $1,000s on a test. I mean, it's ridiculous.
Yeah, we don't
You
want to
don't
do that.
really need it. You don't really need it. So with 9, we recognize this would make it both affordable, in a sense,
Yes.
also will give you, or I should start with that, give you what you need, but do it at an affordable
Yeah.
price.
But
That's really what it comes down
well,
to.
we love that you took that into consideration and trust your scientific judgment on that that the 9 points are when you do them at the right times. You have to follow the instructions.
That's
You'll
it.
do the first one on day 7, as you said, then day 10, and so on. And you'll catch things. And then you also have the what's called the normal pattern, which is the
It's
white
there.
dots.
Yeah.
Here's what it should look like. Here's you.
Yeah.
And that is just so revealing, and in a way, it's
Saving.
emancipating for a person to figure out, wow, now we know, and now we can proceed with the proper solution. So that's been
Exactly.
fantastic. Dr. Gonshor, anything you want to add to the beauty and ease of using a Fluids IQ cycle map?
Well, I will tell you, one of the things that always was wonderful is the fact that it's done in saliva. You know, we
Yeah,
we we don't we don't discuss it often enough. You wouldn't do this in blood for a number of reasons. Number one, you wouldn't get the right result. Number two, can you imagine that you're either puncturing or you're getting someone to go to the clinic? I mean, it's ridiculous. It is
yes,
not necessary. It's not invasive. And so you end up with a non-invasive test where every morning for a few moments you go drool into a tube and you just leave it for the month, leave it there in the freezer so that it is sitting there, and then you send it to us. It's very straightforward. And one of the things which we don't talk about often enough is that people will be sent for all kinds of tests. And there are studies which show that upwards of 30% or more of people never do the test because of phobias. They don't want to be punctured. I don't blame them. And
yes,
so a lot of people just never get it done. And here you're doing something 9 times in a month. And so if it's non-invasive, done in saliva, it is wonderful. And by the way, saliva gives you very accurate results. Isn't that wonderful? I
yeah.
think it's a fabulous thing to be able to do.
Yeah, I agree completely. I started using saliva in 1999, so that's a long time ago. We've run thousands and thousands of these labs, and so we know they're reliable, and they give you the bioavailable levels in real time, and that's never been a question for us. There's over 300 white papers written on saliva and the accuracy and viability of that testing. But you mentioned for a minute the blood. I find that in what we talked about in the last episode, if you guys didn't catch it, the last episode we talked about the mucosal barrier assessment, which is a very simple finger prick. So there's no going for venipuncture and the whole thing and trying to find the vein and all that stuff, which is very traumatic for some people.
Yeah.
And so the at-home finger stick test, it's really easy. It's a really good way to get some blood work done.
Oh, it is. I
Yeah.
didn't want to give the impression that it's not, and you're quite right. I mean, it is a wonderful way. Dried blood spot is fabulous. Uh, but saliva for someone who's just going through their day, just drool in, move ahead, and it is really quite good. I did want to
Yes.
mention one other thing before we finish, and
Sure.
we talked about that a little bit earlier. You said something very important. This particular test is a natural both with the stress and hormone profile, which is in saliva, and as well, as I mentioned earlier, when you've decided for whatever reason that you're going to be doing a urinary test for hormones, either the 24-hour or the dried urine Dutch test, whatever it is, I think you need to start thinking of adding this test to whatever that is, whatever you've decided to do, that you bring these together, that this become part of the staple of what you're actually putting together. I think that is an important message I'd like to get across because it happens so often and it is so important to getting an idea of what is going on with the woman in front of you.
Well, we're going to keep our eye on this. And so if you're an FDN and you're working with women, this is not a test for men, but if you're working with women and they're in that age group that they're all stressed out and they're having these problems, run the test that's really going to give you the complete hormone picture. And if you're a consumer or the public listening to this, you latched onto our YouTube channel, whatever it is, just find an FDN practitioner. They all use the FDN Medical Director Program, which is a way to get direct to the consumer, direct to you. These labs, they're done in the convenience of your own home, and they're not expensive, especially relative to what else you might find out there. And
Yep.
so we just really appreciate everybody's attendance today. Dr. Gonshor, as always, you're a pleasure to learn from, and you don't overcomplicate things, but it's obvious that we can go a lot deeper. For that, I recommend anyone the Functional Diagnostic Nutrition Certification Program. That's a program where you learn about 10 years worth of good hardcore stuff in about 10 months. So it took me 10 years to learn. I must be a slow learner, but it took me 10 years to learn what we can teach you in 10 months. And then you could get certified to be running these kind of labs for your friends, family, and for your profession, if it is your chosen line of work, to help others to get healthy, all naturally, drug-free. And thank you again, Dr. Gunshore.
A pleasure. See you soon.